Okay, good afternoon. To start our lesson this afternoon, we're going to discuss the knee diagnosis and decision making. And we will also add into it the simple imaging of the knee, basically focusing on the PCL, ECL, meniscus uh, structure. Okay, let's start. So basically, when you make a diagnosis involving a knee or in any parts of the body, especially in sports injuries, you need to take up the history. So history starts with the complaint of the patient, or that how that situation happens, or when does that situation happen. No? The major symptoms on which to focus for patient presenting with knee-related concerns include pain, disability, instability, mechanical symptoms, stiffness, and swelling. So when it comes to pain, visual analog scale or VAS uh, is very useful. Pain scale is also very useful. Instability that refers to the integrity of the or the stability of the knee. So it's very important for you to note for the static stabilizer of the knee as well as the dynamic. No? Then mechanical symptoms. So in evaluating the mechanical symptoms, it is very important to note for the range of motions as well as the stiffness and swelling also. No, so in swelling you have to palpate rather. So these are the potential etiologies for hemarthrosis of the knee. So you have your ECL, PCL injury, chondral fracture, patellar dislocation, meniscal tear, intra-articular fracture, tear in the deep portion of the joint capsule. So these are mostly this is caused by trauma to the knee. We have also here an etiologies of disease in the knee, which is a traumatic. You say a traumatic, they just appear there. No? So you have pigmented villonodular synovitis, hemangioma, hemophilia, sickle cell anemia, Charcot atrophy or atropathy, pharmacological coagulopathy, and thrombocytopenia. So in physical examinations of the knee requires an in-depth understanding and anatomic structures and functions of these structures because each provocative test, basically in the knee, the special test that is performed is what? Even in the hip. All of these are provocative tests so that you will know what part of the knee or the hips are injured or are missing or not functioning well. So these are all provocative tests because you are trying to initiate or provoke any symptoms to appear. So you have or even signs, right? Code, no? So you have this inspection, palpation, range of motion, strength testing, patellar testing, meniscal testing, ligamentos stability testing, and gait assessment. And also evaluation of weakness and imbalance and assessment of the back, hip, and feet. So these are very important in physical examination. So you start with inspection. When you inspect, you are going to view the knee. Oh, you inspect it superficially. What is the appearance of the patella, where it is located? Is the knee deformed? Is the knee uh, too big compared to the others? No. Then you have your palpations. So inspection. So diagnosis by the visualization that includes your atrophy, effusion, ecchymosis, malalignment, gait abnormalities, extensor mechanism disruption. So all of these can be evaluated through local inspection by just simply viewing the knee or the muscles which is that crosses the knee. You could easily say that it is in atrophy or there's a joint effusion because it is too big, the joint, the knee joint. Ecchymosis, if there's a reddening on the joint line, malalignment, hiwi ang tuhod, balansi, gait abnormalities, maglakaw. So all of these can be seen by our eye. So these are examples. So for atrophy, if there's a sign of atrophy, then you have to measure for the muscle bulk using tape measure, di ba? Muscle bulk measurement, MBM. Well, that is for atrophy. If it is swelling, then you now use the muscle girth, which is different, no? Because in bulk, you have to measure where is the belly. While in muscle girth, you have to measure it by level in, diba? You have there the uh, landmarks, then you have to measure 2 inches above the landmarks, two, then another two, and another two. That's to note if there's really a swelling or an edema of that part. So these are example of ecchymosis. No? Lagub-lagub. Okay, that shows no, na ecchymosis. Kwan po na siya, abrasion diri sa kwan, no? Then you have your palpation. The knee should be palpated for the presence or absence of an effusion. So palpation plays a very important role. So the quadriceps tendon in its patellar insertion should be palpated for both tenderness associated with quadriceps tendonitis, a gap associated with quadriceps tendon tear. The patella should be palpated for prepatellar tenderness or fullness that may be a sign of prepatellar bursitis. The patellar tendon in its patellar origin should be palpated for tenderness. So these are the classic. Diba? Mao na magpalpate ka sa kani patellar tendon man yung palpate kani siya diri ang sa ilalim sa patella, no? Sa femoral condyle. So kung dira sakit na siya, so it could be na-apply ka ngano mo sakit man na siya kaya mo na siya diri nagka-contact sa imong patella. So kung naa na siya abnormal surface diri sa ilalom sa patella, diri bunog na siya dira articular cartilage. Okay? Tibial tubercles insertion niya sa mga tendinitis or Osgood-Schlatter. Okay, so ana, no? Palpation. Yeah. These are palpation technique. Then you have your range of motion and strength testing. So usually when you do your range of motion, also you should couple it with the MMT para short lang ang time, ba? Pagkuha nimo sa range, full range, automatic pag down niya, ipa-hold sa nimo, ayan, butangan nimo og resistance. So automatic kung ma-resist, that's already 5, di ba? Ano man na, o pagka complete niya sa range against gravity, that's already 3. So a terminal extension many persons have up to 5 degrees of hyperextension, which is a combination with range from 0 to 10 degrees of flexion. May be useful for the screw-home mechanisms of internal rotation that tensions the cruciate ligaments and locks the knee at full extensions. So 125 degrees of flexions are necessary to squat, whereas 110 degrees of flexions are required to descend stairs in normal fashion. So let's take note of that, no? Because if your patient, if you get the ROM and the ROM is below 125, of course, your patients will suffer from. He cannot lower his body even by going to the bathroom or to the bathroom or to the CR to sit down and to defecate. Or if it is a woman to urinate, then she would have a very difficult uh, she would encounter a very difficult process, no? Maglisod siya pangihi, bumabayi. So, ato nang bantayan. The loose of a little as 10 degrees of flexion will affect running speed. The loose of as little as 5 degrees of extension can cause a limp with increased quadriceps activation and later on quadriceps pain and fatigue and patellofemoral pain syndrome. Differences between passive and active range of motion should be noted. So the when you get to ROM, you would also note for the normal side. No? So, range of motion testing is an excellent time to assess muscular strength, including hip abduction, deflection, extension, ankle flexion, and extension, foot eversion, inversion, extensor of the hallux. In a patient with demonstrable weakness, one must determine whether neuromuscular inhibition due to pain may be contributory, or sometimes maybe this there was an injury with the peroneal nerve as it passes to the uh, lateral to the anterior tubercle, no, of the tibia. Okay. So vascular status of the limb should be also evaluated using palpation. Diba? Let's say for example, ng possible rimas tuhod, so yun siyang i-palpate ang distal pulses, dorsalis pedis, no? Pulse on the posterior tibial. So, yun mo na siyang i-assist dito. Kaya nga naman, base na ay problema po siya. Yahang blood vessel, such as femoral artery or in compartment syndrome, base na i-appeal o ipit ang artery niya, no? Sa artery compartment syndrome. Then patella. So you have to assess the retinaculum of the patella and peripatellar capsular structure. The examiner can assess the patella mobility with the knee extension before it engages with the trochlea. So this is one method of assessing the patella in the case of its mobility. So you can only assess this when the knee is in full extension. But of course, you can also assess the some in flexion, such as this one. So here, usually ang gina-assess na sa PT is not only the tracking or the movement of the patella, but as well as the pathological uh, conditions found maybe below sa beneath the patella. So base na siya kung binak na siya crepitus or whatever, then maybe na siya osteoarthritis, no? So inapalpit na during extension. Pag-extend sa knee kay iya man ang ma-feel, no, kung crepitus or even during flexion as the patella tends to contact with the condyle of the humerus. Then you have also patellar apprehension. So in patellar apprehension, that is testing the patella, no, if it is unstable or not. So here you are looking for the reaction of the face on the patient, no. So kung dislocatable ni siya, makita nimo na sa pasyente nga pag apply nimo ani niya lateral or medial, naasa to dapit ang area nga na dislocate na siya before, kunya unstable siya dira, makita nimo yang nawong magwiit layo pa, no? Kulbaan. Then lateral pateral maltracking, so which means the patella tracks laterally. So usually it is caused by muscle pull imbalance. So then you have your meniscus. The meniscus, the most commonly used provocative meniscal test is the McMurray. Kabalo naman tayo na kung saan na siya, di ba? O then you have your Aplis, no? Ang McMurray, it is done in supine, while the Aplis is done in prone with knee flex in 90 degrees, no? Ligamental stability testing in the knee is among the most difficult to learn aspect of physical examination, and also one of the most important portion of the examinations. So first, for the ACL, the most sensitive test is your Lachman or anterior drawer test. And sa PCL, you have your posterior drawer. So here now is the synthesis in making decisions for the knee. So if you have knee pain, you must determine its laterality where it is located. So if it is located anterior, you consider these following conditions. So you have to check. If it is anterior, you have to check for the rotational alignment, Q angle, core strength, gait, patellar tracking, effusion, palpation. See, ana. So mostly, pag anterior, ang pinaka-involved niya is the patella. Diba? Tanawan ninyo. So, diri kay naaman dira ang patella dapit. Kung nasa sa medial side, then you have to consider this one. So, meniscus, MCL injury, pes ansereno's bursitis, medial plica syndrome. Then, these are the physical examination that should be done and the special test. For lateral, it is almost similar to this one. They only differ in the involved ligaments. Diba? Parehara, special test na mo, McMurray. O, direra, valgus ang pikas, kay medial man, varus ang pikas. Pero parehara na sila da. Diffuse, when you say diffuse, katag. So, muna siya nga conditions. When you say diffuse katag ba, ang pain niya, direra sa isa ka area sa knee. So, it is more on cerebral area. So, inana. No? So, you consider, so if it is diffuse, you should consider the hip exam because it might be a referred pain, no, coming from the hip. So this is your decision making. Then you have your instability. So if knee instability, so these are the test, the algorithm that you should follow. Then for patellar, but if you're going to look at it, katong patellar nimo, the same lang na siya sa medyo na siya similarity sa anterior, di ba? And kani, this is a combination of the three, medial, lateral, and diffuse. Look at this, so. Napa na siya hip, di ba? Lachman, dial test, quadriceps. So, no? Then let's go now to the imaging of the knee. So in imaging of the knee, I did not touch other imaging because according to textbook, MRI is the well accepted as the primary non-invasive imaging modality for the global assessment of the knee accurately, which defects, abnormalities of the ligaments, tendons, meniscus, articular cartilage, and bones. It has high negative predictive value with regards to the knee. So, inana. So, to, mas taas ka ng MRI. So, MRI lang atong consider. Okay? When X-ray, dali ka man na makita kay basically it's bone, no? So, MRI, the presence of meniscal pathology is the most common reason for knee arthroscopy, and MRI is well accepted as an accurate invasive preoperative screening method for meniscal evaluation. So, let's go now to the normal, no? So, basically, itom ang appearance sa MRI nimo kung normal siya, no? Itom, dili siya puti, no? Especially kung sa T2, no? Itom siya. Di man siya vascular magod siya. So, inani. So, example ana. Here, there's a tear, no? Kita gini mo siya disrupted. So once nga na gani siya gisi, kita din mo kay ito man siya. So maput akatong ginisian niya magawas ito as puti. Ano? Okay? Of course kanay cyst man na fluid pero na pa siya gisi sa lateral, no? So pitfall sa imong MRI with regards to detection of meniscal pathology is MRI artifact. So, artifact yun, no? So, usually, kay maglihok-lihok man tuhod. Hindi man punggan sa normal anatomical structure nga duol dito. No? Duol sa imuhang gi-evaluate. Muna siya mag-mimic. So, usahay, kay yung kagwalay injury, pero na ito, kay naman, duol siya sa, let's take for example, ang posterior cruciate. So, ah doon siya sa popliteus o usahay sa meniscus. No? So, bantayanan, no? Kung maduol siya sa normal structure. So, inana. So, we have the anterior cruciate ligament. Okay, so these are normal, no? Kani normal, kani ang abnormal sa na is a discoid lateral meniscus. Kani siya, oh. So, ipabre nagpilo na siya. Supposedly thin na siya dira, wala na siya sa tunga kaning nagana. No, so nagloko na. Naglukot siya. Okay, so usually it's a nag-couple ni siya sa injury sa muhang anterior cruciate, no, ang discoid. Usually unstable naman ang anterior, so mag-rotate na siya dito. So we have here complete disruption on the ECL. This is the ECL. Amo niyang continuation mo niyang end nga isa. So, putol siya, supposedly sumpay na siya dira. This is the PCL, no? So ani fluid ni siya nga na-collect. Okay, so this is a posterior cruciate that is intact. This one, wala na siya. So, kanina pa. So, kung mo tanaw, kanina fiber ni siya sa mga posterior cruciate. No? Nagkatag. Bungkag. Kanina anterior cruciate. No? Kanina. So, dira na siya class. No? So, these are classic images. Anyway, there are other images still found in the book. I think chapter 96. No? Napa na siya dito. So, please kindly check it. No? And read other pitfalls, especially involving anterior cruciate and posterior cruciate ligament. Thank you for listening. I'll see you next week.